Hey, welcome back to the Helpful Pharmacist weekly live stream. For anyone that's watching, I apologize. I clicked the wrong button. I'm trying to enhance the audio and I clicked the wrong option and there was no way to fix it once I was in it and I had to start from the beginning. So again, my name is Chris Regas. I am a pharmacist and the Helpful Pharmacist, hopefully. I'm a biochemist by training and also a pharmacist as well. Today, again, like I said, we're taking questions and talking about all things health related. And the topic I have to go over today is going to be treating diabetes, specifically type 1 and type 2, and more of an emphasis on type 2 just because there's more drugs that go into that treatment there. If you guys have any questions, feel free to put them in the chat. That way I can personalize the information and give you the most information possible. So today, again, we're going over the treatment options of diabetes. The focus is going to be on the pharmaceutical options. And the reason why I say that is so much of diabetes management is lifestyle. And that definitely can't be underemphasized here. I'm not going to include that. Otherwise, this talk would last a lot longer than it's going to. I'm just going to focus on the drugs. I just want to mention that, again, lifestyle modifications include weight management, such as BMI, diet, including avoiding processed foods, high carbs, large portions, and lots of calories. Exercise plays a major role, and also smoking cessation, just to touch on the lifestyle modifications. And again, the big focus for here is knowledge is power. There's so many patients I talk to that just don't, unfortunately, understand their treatment. And when something's not being done optimally, they can't really communicate it to their provider. And a lot of people go undertreated for a long time. I just had a new patient, in fact, that I onboarded last week, and this was definitely their case. Their insulin dose was wrong. Their oral meds were wrong. They were missing a lot of things, and it's definitely a huge part of why they're not succeeding or conquering their diabetes. Just kind of that example. So before we get into the drugs, there's some kind of ground ideas we need to go over real quick, which is how are we going to evaluate the benefit or how are we going to compare these? So typically it's going to be A1C. A1C is a lab that you get. They take a small little drop of blood and they can basically tell what your blood sugar was for the last 90 days and they put it in a percentage. It's typically between 5 and 10. So under 5.7 is considered the goal. Between 5.7 and 6.5 is considered pre-diabetic, and above 6.5 is typically diabetic, just so we're on that page. And what you're typically going to see here is most of these medications, they have a somewhat similar benefit of A1C reduction, which is typically about 1 to 2%. So again, if you had an A1C of 7, you took one med, it might go down by 1 or 2 points. That puts you between 5 and 6. But the reason why I mention this is if when you are diabetic, or when you're diagnosed, I mean to say, if you're diagnosed a little bit later on, which is pretty common, unfortunately, because people don't get their A1C tested, you may need more than one medication. So for example, if you're diagnosed and your A1C is 9 and each medication really only does 1 or 1.5%, basically one medication is not going to be enough. You're going to need at least 2. If you're diagnosed and your A1C is only around 7, you're probably going to be okay with just one medication as long as you make the lifestyle modifications. However, if you're diagnosed with an A1C that's higher, typically over 10, they may actually just decide to start you on insulin. And that's because if your goal was to go from 10 to 6 and each med only does 1%, let's say, that would be 4 meds. And oftentimes the patient can't tolerate all 4 meds, or it's going to take a long time. There's a risk for side effects, other complications. And so oftentimes they're going to start you on insulin. So just to kind of throw a quick little benefit of why you want to get tested now for your A1C and why you want to start working on your diabetes management now if you have it, is that if you do delay and push the inevitable, and when you are diagnosed or you go to get treatment, your A1C is over 10, you're most likely going to start on insulin. And most people don't want to give themselves injections. So again, like I said, the biggest takeaway is don't wait. The longer you wait, the harder it is and the worse your options are going to be. And you might end up in a situation where you have to inject yourself, which obviously nobody wants. The other big thing on a more positive note is there's a lot of really good options today for treating diabetes, especially type 2, especially compared to the last 20, 30, 40 years. So there's definitely some encouragement there. Outcomes have never been better for patients who are fully compliant, do all the lifestyle modifications, and are on the proper medications. And I also just want to make a plug or a disclaimer here that if you have the ability to, through your insurance, through your ability to afford it, through your doctor, the newer medications almost always work better. Typically, without many exceptions, the newer the medication is, they work better. We're going to talk about those today, so I'll give those examples. But that's another really important point. The patient I worked with last week, they are on multiple older medications, and I'm sure that's a part of the reason why they're not meeting their treatment goals. Okay, so just to kind of get that started. And again, just another way to reemphasize that, is that you get what you pay for, which is kind of a common thing most people are aware of. Pharmacy is usually not different. There are some cases where the cheaper generic medications are just as good or better, but typically when the cutting edge medications are only brand, there's a reason why they're brand and the cutting edge medications. And I definitely encourage patients to get those when they can afford them if they're an option, and diabetes is definitely no exception. So the example I have for this, because again, the common complaint we get in the pharmacy is my copay is too expensive, I can't afford it. What's this insurance company doing? I'm paying all this money for insurance, I'm not getting anything, I'm frustrated. And I get it, I definitely understand it. And again, I'm gonna educate you real quick right now, just like I would if you came in the pharmacy. So what a lot of people don't realize is when it comes to drug costs, generally speaking, the insurance company is paying between 80 and 95% of the cost of the medication. So a lot of times the patient comes in, they see the copay, it's like $47, it's $90. Like, oh, why is it so expensive? I don't want to pay that much. Typically what I will tell them just to start off is, obviously I understand it's expensive and money's not unlimited. So I'm sorry, I feel bad for you on that. But one thing that may help you feel a bit better is I'm going to actually tell you what the cost of the medication is to help you realize for that $50 or $100 how much benefit you're actually getting. So a lot of these medications, they actually cost between $500 and $1,000 a month for the cost of the drug, which means when your copay is $50 or $100, the insurance company is paying the overwhelming majority of it. So for example, just to pick an easy one, if you came in and you got Ozempic because you're diabetic, and let's say your copay is $47, that means the insurance company is spending about $900 there. So although the $47 is not a small amount of money, I like to think that when I explain to the patient, well, actually that medication typically costs around $1,000 a month. And for your $47, you're actually getting almost $1,000 of medication. That at least helps people understand there's value there. They're not the only ones paying. And when they realize that they're only paying about 5 to 10% of what the insurance company is paying, which is sometimes the case, it makes them feel a little bit better. Other point I want to make here is my personal and professional advice is definitely diabetes is not the time in your life to cut costs. Typically, like I said, there's a reason why these expensive medications are more expensive. Typically, it's because they work better. And as we'll see in the following slides, working better also means treating or preventing complications. And if you saw our video last week about diabetic complications, you understand that diabetes is a disease of complications, which makes the medication that treats or prevents complications almost the most important therapy. So definitely the idea that I want to convey here is you get what you pay for. And there's a big difference between the luxury protocol and the bare bones protocols. So I'm going to start with type 2 diabetes. I know 1 and then 2, they go in order, but we're starting with 2 because most people who are listening are going to be type 2 diabetic. It's about 90% of diabetes patients out there. Just to give a quick background, so we're on the same page here, in a very simplified fashion or form, diabetes type 2 is a lack of enough insulin or insulin resistance, or both typically. So you can't make that much insulin anymore, so you have a shortage of it. And because of your prior history, you're now resistant to insulin, which means that when the insulin molecule binds to cells, it doesn't do a lot. So if you don't have enough insulin and the insulin you have doesn't do much, you have a problem. In this case, it's diabetes. The insulin helps move the sugar or the glucose from the blood into the cells. And when the insulin isn't present to do that, or doesn't work when it is present, you get elevated blood sugar, which is what diabetes is. To give that quick background. For type 2, there are quite a few medications that we're going to go over, but just kind of give you some examples of how they work. Some of the things they can do is they can actually increase the amount of insulin you release. They can change the hormones that regulate insulin. They can change how the kidney processes sugar or glucose, which we'll see is a really big component. And we can also modify how the liver makes or process sugars or responds to insulin, just to give some quick basic background aspects. And I also want to include that typically with all medications, diabetes is no different. They're usually prescribed in order. So today I'm going to go through the medications in the order in which they're prescribed. We call it a decision tree. So it basically forks out, and depending on where you are at that fork, determines which medications you may benefit from most. So that's the way I'm going to present them. And again, just to reiterate, if your A1C is more than 1.5% over goal, you're going to typically need more than one medication. If it's less than 1.5% over goal, you may get away with just one. And if it's over 10, you may end up having to start with insulin. So definitely where you are when you start determines how many medications you're going to need, which again is why starting as soon as possible. We're getting diagnosed as soon as possible. We're getting your A1C measured every single year so you can know where you stand. All have a lot of value. So when we talk about type 2 diabetes and oral management, the first medication is always the simplest. It kind of makes for a very easy start your conversation, which is kind of nice as a provider. You know what the answer is going to be. In this case, it's metformin. And the little explanation that you hear growing up is it's first on, last off. When a patient gets diagnosed, there's a real concern. It's always the first medication we add. And with very few exceptions, we never take it off. One of the common reasons you would take it off is a kidney issue, but again, that's some more detail we're not going into. The reason being is it works really well. It typically lowers your A1C by 1 to 1.5%, which is a lot. It's safe, it's cheap, and it's generally very well tolerated. So when we're talking about medicine, that's about as good as it gets. People always ask me, is metformin safe? The answer I give them is there's probably been more doses of metformin administered to humans than any other medication in the history of the world. And there's very little negative data that's come out. There's very few serious side effects or consequences, which is why we can all confidently say the database is extremely safe. And it's also very cheap, so it's convenient there. I want to mention that it comes in an IR instant release and an XR extended release version. Almost everyone should be on the XR version, just to include that. I see that all the time, including my patients. And if they're not on the XR version, the dose is typically between 1 and 2,000 milligrams a day, although the max dose is 2,500 milligrams. So for a lot of patients, they want to max that out to get the most benefit before they add to their medication. And typically you want to take it with food. And the reason why you want to take it with food, like I said, the main side effect is GI issues. And how I explain it to people is if you have a GI issue from metformin, you're going to know it. If you don't know if you have one or not, you most likely don't, because the GI issue happens very quickly within the first couple of weeks. Basically, you get diarrhea, loose stools, lots of stomach pains. You're going to know it if you have it. So if you're on metformin and you don't have those issues, you most likely aren't having any side effects, because that's the main issue. And then in terms of how it works, part of why it's so beneficial, it has a very broad profile of benefits. So kind of going in order, it will increase the sensitivity of the insulin, which is obviously important because we said before that diabetes is a disease of insulin resistance. So it reduces that. It also increases the uptake of the glucose in the cells, which again is a part of the problem. Diabetes is elevated blood sugar, and that's because the sugar or glucose can't absorb into the cells or the tissue, so it fixes that. It can also help decrease some of the absorption of glucose, so less glucose gets into your body from your diet. And it also turns out that your liver can make forms of sugar, which can elevate your blood sugar and helps minimize that. So in terms of where it works on all the places we want. It's well tolerated, it's cheap, it's effective. Metformin's good to go. That's why it's almost always the first line medication with very little deviation from that. Once we get past the first medication, that's where the tree forks and the conversation gets a little more complicated. So before I get into the drugs, I want to basically preface here that typically what determines what drugs are used after metformin is going to be cost in your insurance formulary. That's because most of these medications are branded, which means they're expensive, and your insurance company may not cover that specific medication. It may not cover that specific class. That's called a formulary, or they may require you to have met certain requirements. You have to be on metformin for 2 or 3 years before they'll cover that one, whatever it may be. So that can be an issue. And then if it is covered, the copays can be expensive. So like I used in the example before, $50 copay is not uncommon, even $100 copay. Some people can't afford that. So for them, it's going to be an issue. But like I said, diabetes medications is not a place to cut corners. So please, 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 if that is an option and you can find a way to make it work, if I were you, I would do it, because when you see how these medications work, there's a big difference. So with that said, typically where it forks for the next medications, the more expensive ones, they're typically at $500 to $1,000 a month in cost. Those are going to be your SGLT2s like Jardiance and Farxiga, work on the kidney, or your GLP-1 or your GIPs, which are the once weekly injections, typically called Ozempic and Mounjaro. Those are definitely the cutting edge ones. And if you can afford those, that's what we want to see. The less expensive ones are typically going to be the DPP4 ones, which is Januvia, sulfonylureas such as glipizide, and thiolinidides such as pioglitazone, which I definitely don't like to see in any of my patients. And those last three, the Januvia, glipizide, and pioglitazone, they typically cost between $100 and $100 a month. Januvia is the expensive one there. All the other ones are relatively inexpensive. So again, there's a pretty big cost difference there. And Januvia can be a little bit more, but there's generics available now. So like I said, the next med is a little complicated. So I'm going to preface this as type 2 ideal next meds. The main questions we're going to ask here is what is your weight? Do you have kidney disease? And do you have cardiovascular disease? And depending on that, we're going to use either the SGLT2 or the GLP-1 first. The SGLT2 is the one that is typically definitely better for kidney issues. and also often better for cardiovascular disease issues, although there's more and more data coming out about GLP-1s for cardiovascular benefit. For the simplicity, I'm going to say that the SGLT2 is better for cardiovascular disease. That's because the kidney and the heart are very connected. When you have a kidney problem, you have a heart problem and vice versa. And so because this medication, the SGLT2, works in the kidney, that's why it has such a benefit cardiovascular disease profile. And as we mentioned in prior videos, unfortunately, cardiovascular disease is the number one cause of death of diabetics, which makes a medication that can really work on cardiovascular disease super beneficial for diabetes. And that's why I personally am still really excited about these medications. Again, they're Jardiance and Farxiga typically, because they lower the blood sugar, they protect the kidney, they protect the heart, and they protect the kidney and the heart from causing real problems, which is a really big benefit. They're typically really well tolerated, and they typically can lower the A1C between 0.5% and 1%, which again, as you can see now, is not as much as metformin, but because they treat the complications, and as we talked in prior videos, diabetes is the disease of complications. It's not just an A1C benefit that you're getting here. You're getting the risk of cardiovascular disease and the risk of kidney disease. They're generally well tolerated. The big ones are going to be increased risk of UTIs, especially for female patients, and also what I describe as gynecological skin infections. The reason being is how they work is SGLT2s, is they increase the amount of sugar in your urine, which pulls out your body. But because there are bacteria and other things that live in your gynecological genital parts, that higher concentration of sugar makes it prone for bacterial skin infections. So you have to keep an eye on this. I've had a bunch of patients that did have this. Again, not to make anyone afraid of using this. I would use it. I'm talking about 10 patients out of 500 that I've spoken with that have this issue. So again, it's not super common. And it's something that you can catch and be prophylactically prepared for. What's also cool about these is they're just one pill you take a day, which is really easy. And kind of because it has complication benefit, it has A1C reduction, has minimal side effects. It's an oral pill that's once a day. That's why I kind of call this the one the new standard. This is what I want to see all my patients on. Again, the issue here though is the cost. The cost of the drug itself is about $600 a month, which means that your copay, depending on what your insurance is, it could be anywhere from $10 to $100 a month, which for some people is going to be an issue. I do also want to make a quick aside here is that if you have commercial insurance, which means you're not on Medicare or Medi-Cal or on permanent disability, you have commercial insurance, typically most of these drug companies will give you 3 to 12 months of drug either for free at a very low cost. So that's a little aside there. Most of my patients are typically on government insurance, so it doesn't apply to them. But I want to mention that there for the younger people who have commercial insurance. There are additional ways to get copay reduction through the manufacturer on these drugs. The next one that we mentioned, which is our second choice or our third choice, depending on how we're looking at it, these are going to be the diabetes medications that also have weight management benefits. And they do also lower cardiovascular disease, but the focus here is primarily on weight. Again, these are going to be the GLP-1s like Ozempic or the GIPs like Mounjaro. These things are really cool. They came out 4 or 5 years ago and they're really great. So definitely for diabetes, it's a good drug to be on, especially because diabetes is, a disease of diet oftentimes, eating too much, eating the wrong foods. So because these medications change the way you view food and intake food, they can be very powerful. They are a once weekly injection, so it is an injection, but I really haven't had too many patients complain. Again, probably because it's just once weekly versus once daily or multiple times a day. And people are pretty excited about the weight loss benefit. How it works is it's pretty cool. There is basically some hormones in your stomach that regulate how full you are. They talk to the brain. They also regulate the insulin secretion, and this drug basically enhances or mimics those. So some of the examples are it basically increases the insulin secretion. It decreases glucagon. Glucagon is bad for diabetes, so it basically turns that system off or down. It helps slow the gastric emptying, which basically reduces the peak of the blood sugar. So it lowers the peak, it takes longer to absorb what you have in your stomach. That's also why it helps you lose weight in part, because it makes you feel fuller for longer. So you can't eat as much, or you don't think about food between meals because your body takes longer to digest. And then the last one, again, like I just said, is again, decreased food intake. So there's some benefits there. Obviously, these medications work, especially for weight loss. Typically speaking, you're looking at between 7 and 12% of your total body weight loss within the first year or the first 18 months, which is really big, especially for diabetic patients, because we know that as we decrease our weight, it's going to typically improve our A1C. So just to put those benefits in some more simple language, you don't feel hungry. You're not going to eat as much, which is where part of the weight loss comes from. It lowers your liver's ability to produce sugars, which for a lot of people increases their blood sugar in a bad way, and also allows your body to make more insulin. So obviously we can see how that makes sense. The side effect profile, I'm just going to leave it in a simple answer here, is generally well tolerated. It's mainly GI issues, nausea, vomiting, loose stools, diarrhea, abdominal discomfort. Typically seems to be the case. I think part of this is due to people dosing it too high. So I personally recommend not going above 1 milligram per week as the dose, although a lot of people use 2. And definitely tapering the dose up slowly, so don't start at the highest dose. And a lot of doctors out there are seeing this and they're starting to use a lower max dose. So there's definitely ways to minimize those side effects and look at the benefits. It does lower the A1C by 1 to 2%, which is quite a bit. Like we said, it's going to be more than the SGLT2s. And it is relatively expensive at about $1,000 a month in drug cost. So for people who are diabetic, where it is indicated, their copays may be an issue. Again, if you're not using it for diabetes, it's not typically covered for weight loss, although they are working on those indications. So if you are not diabetic and you're trying to use it, it's going to be more difficult to get it covered. Usually they pay cash, and the prescriber may not want to use it. But again, I just think this is a really cool comparison between the two for the SGLT2s like Jardiance and the GIPs like Ozempic. We have these new really cool classes of medications. They do multiple things: weight loss, A1C, kidney protection, cardiovascular disease protection. They're doing multiple things. And we can also use these medications together for patients where it's either indicated or they can afford it. You're actually able to use 2 of the best diabetes medications ever at the same time, which gets me really excited from a care standpoint, because I definitely know and believe those 2 medications together are cutting edge, and the benefit you're going to get is definitely a lot more than the other options. So typically those are the first 2 we're going to look at, and depending on cardiovascular disease or weight risk, we're going to decide which one to use first. And it's very common to see both in patients. Now on to the less expensive medications. These are going to be for the people who either don't have great insurance or can't afford copays or have no insurance at all. So the first one is going to be the DPPs. It's dipetyl peptidase 4 inhibitors for those who want to follow. It's basically an enzyme that breaks down the hormones, and this drug basically prevents that. So just like the GIPs, like Ozempic, influence the enzymes in your GI tract and it gives you the benefit, this is a little bit of a simpler way of doing that doesn't work as well. So it is not a bad medication. It's just not the standard cutting edge. The A1C reduction is not that great. It's between 0.5% and 1%, so definitely puts on the lower end. And it does have, side effects, primarily GI issues, nausea, vomiting, stomach pain, which some people can't tolerate. And it has been known to cause a little bit of a skin issue or skin rash. Some of the examples of this one are going to be Januvia, Tradjenta, and Nesina. Again, some of these are available generic, which drives the cost down a little bit. And typically your copays are definitely going to be less than they would be for things like Jardiance and Ozempic because of that. So I think personally, if I wasn't going to be on SGLT2 and I wasn't going to be on Ozempic, I had to go to the next one. This is the one I would pick. I would typically be on Januvia. It's been well studied. It works pretty well. There's not too many serious side effects. It's not a bad medication, and the price has gone down on it. So that's typically, just take a quick pause here, for type 2, metformin, and then either SGLT2 or something like Ozempic or both for your 3 meds if you need it. And if you can't afford the SGLT2 or the Ozempic, something like Januvia would be a great next choice. And then maybe at that point, you would decide to use the SGLT2 as your 3rd medication, because at that point, things are getting serious. You want to invest a little bit more into your health. And at the same time, if I'm being honest, the next medications aren't that great. So once we get past those 4 medication classes, it kind of goes like this, not in a good way, for efficacy and benefit. And this is where I really start to cringe when I'm looking at patients' med list. The next one that I see really commonly is sulfonylurea. The common example is glipizide. It's a dirt cheap medication. It costs dollars a month. It does reduce your A1C well from 1 to 2%, but there's other issues and concerns. So the first one is that the studies have shown that it only typically works for 5 or 10 years. And unfortunately, patients stay on it for a lot longer than that. I just had a patient a couple of weeks ago. They've been on it for 20 years. So I told them, I really doubt this medication's working, and it's probably definitely playing a role in your issues, as well as just because a medication doesn't work doesn't mean the side effects go away. So there are GI issues, there's weight gain, there's fluid retention, so you could potentially have those side effects without a lot of benefit. So I typically don't like seeing these, and I especially don't like seeing these in patients over 65, because they do have a risk or increased risk for low blood sugar, hypoglycemia. And if you're still in that first 5 or 10 years and it's working, that is a real risk or a real concern. especially in geriatric patients over 65. So I typically don't like seeing in that population because it does cause low blood sugar, which is a real risk for them. They get low blood sugar, they get dizzy, they get confused, they get memory issues, they get cognitive issues, they can fall. It's not good. But out of the medications that are left, this is probably the one that I would endorse the most because it works pretty well and it's a little bit safer. The next one is pioglitazone. It's from a very difficult drug class to say, so I apologize in advance, but it's thiolinonides is how you would pronounce it. And basically how they work is they change the way the body processes fat, and they basically increase the absorption of sugar into the muscles, which sounds great. But the problem here is it's been linked with weight gain, fluid retention, and certain types of cardiovascular disease risk. So the study that I found today, and there's multiple, is that it increased the edema and heart failure requiring hospitalization in type 2 patients with a 43% increased risk of heart attacks and a 64% greater risk of cardiovascular death. And I believe those statistics were for patients that were moderate or severe. Those were not for all patients, but how I was educated on this one is it definitely increased the risk for certain cardiovascular diseases. And because we know that diabetes is the leading cause of cardiovascular disease, you don't see this medication used very often. At the same time, we don't want to retain water, we don't want to gain weight. So there's a lot of secondary side effects here that are not ideal for diabetics, which is why as soon as I see this one, I typically always call the doctor and try to switch out for an alternative, again, because of the cardiovascular disease risk. It does have an A1C reduction of between 1 and 1.5%, which is good. But again, like I said, there's a lot of side effects here. So those are actually, believe it or not, going to be the main medications we're going to see with diabetic patients. Typically, we're going to see between 2 and 4 medications. It's going to be some combination of that. Again, my preference would always be metformin, something like Jardiance for SGLT2, some type of weekly injectable like Ozempic. And then if that's not enough, something like Januvia to round it out for your 4 meds. Typically, if that's not going to be enough, you're going to have to look at something like insulin. So ideally, in a perfect world, no one would have to go those other medications that I mentioned that don't work as well or have safety issues. And then to round it out for treatment for type 2 diabetics, typically most all of them are going to have a risk for cardiovascular disease, like we said. It's typically between a 2 and 3-fold increased risk. And that comes along with our concern for building up of fats or cholesterol in the blood vessels, atherosclerosis, which can cause embolisms, DVTs, occlusions, coronary artery disease, things like that. Really big risk or concern. So typically most of those patients are going to have a statin, something like a atorvastatin, simvastatin, rosuvastatin. Those are the most common ones we're going to see. There's some controversy out there on those. We're not going to get into that right now. I'll just mention it real quickly here. Typically, these medications are well tolerated and they do work really well. The common side effects are going to be GI issues, muscle pains. That's the most common one. So like 5 to 15% of patients, they can't tolerate these. They get cramps in their calves, thighs, or lower back, typically in the first couple months. And you just educate them if that occurs, tell your doctor. They can either decrease the dose, change it to a statin that doesn't work as well but has less side effects, or just discontinue altogether. But I think if I was a patient, I was diabetic, I definitely would be on a statin. And that's because statins are used to lower LDL cholesterol. And basically every study that has tested the benefits of lowering LDL cholesterol has shown benefits, which is why typically the current recommendation is as low as possible for LDL, just to give that example. There are also some concerns with memory issues, and I think this is a valid concern. However, when I did some quick research before I made this, a lot of the studies that I found show that there's no long-term decline. So for the first 3 to 6 months, there may be some short-term memory issues, but either long-term or once they were discontinued, those effects went away. And again, in medicine, it's risk versus benefit. So yes, there is some risk there, although it's not super common, but the benefit is very much known. Again, because occlusions and buildup of plaques is one of the number 1 causes of death. I do also want to mention that diabetes as itself is a risk factor for other illnesses such as cardiovascular disease and hypertension, and all of those are also risk factors for memory. So I just personally, anecdotally, wonder if is it the statin itself, or is it that patient is also a risk factor and it's a combination. So I just want to point out that if you have diabetes, cardiovascular disease, or high blood pressure, those are all risk factors for memory issues. And so I just wonder how much of the statin is to blame for that. I'm sure it's a bit of both. I also want to mention that certain people recommend taking a supplement called CoQ10. I'm one of those people. When you're taking a statin, the reason being is when you take a statin, it blocks the production of CoQ10. and CoQ10 is necessary in the mitochondria to make energy, and the brain is the most energy consuming organism or tissue in the body, organ in the body. So to me, intuitively makes sense that if you took a drug that blocks something that your body needs to make energy, and the brain needs more energy than anything else, you may have a decline in your brain function. I see a correlation there. So that's why I recommend all patients on statins take CoQ10. There's not a lot of evidence around it right now in terms of memory reduction, but I personally think it definitely helps. And then just to round it out on statins, if you absolutely can't tolerate them, there is an injectable class called PCSK9s. That's going to be medications called Repatha and Praluent. These are typically injected once or twice a month. They work much better than the statins in terms of lowering your LDL. They typically don't have a lot of side effects, but the issue is they're more expensive and the insurance companies won't cover them unless you can document you had a bad reaction to statin or you had really serious cardiovascular issues while still on a statin. That's when they're going to get covered. So again, those are the type 2 diabetes medications. There's typically between 4 and 7 classes depending on how you look at it. And to me, it's very clear which ones you want to be on and which ones you don't want to be on. So I hope that was communicated today. And definitely, I hope my excitement for some of these medications came across, especially the SGLT2s like Jardiance and the GLP-1s like Ozempic. They are really cool medications that work really well. And they're definitely going to change how we treat diabetes and how diabetes or diabetics live with it. Definitely increasing their lifespan, decreasing the complications, which is really exciting for us. And again, encouraging people, get your A1C tested because the sooner you get diagnosed, the sooner you've been on these medications, it's just going to be better for you. Okay. Now we're going to switch to type 2 diabetes, which is a little different. Typically, almost all the drugs we just mentioned are not going to be used in type 2 diabetes, type 1 diabetes, because of the mechanism difference. So in a quick nutshell, type 1 diabetes is thought to occur due to an autoimmune issue, most likely a viral infection. So you have some type of viral infection, which causes the immune system to kind of go haywire, and it begins to attack the cells that are making insulin. And when you lose those cells, obviously you can't make any more insulin, and that's generally speaking how type 1 works. The reason why I'm saying that is that in type 1 diabetes, you basically don't make insulin, very little insulin, and as it goes on, you make less and less and less. So the main hallmark for type 1 is insulin replacement, which most people understand is going to be insulin injections. And as a quick aside, that's why we can't use most of the type 2 diabetes medications, is because those medications try to cause the body to make more insulin. But since we can't make insulin in type 1, they don't work. They're not studied, they're not recommended. So I just want to make sure we're clear on that before we get into it. We have to replace the insulin with pharmaceuticals because we don't make it. It's typically dosed by weight. I'm not really going to get too much in the dosing because that's for your doctor to decide. There's some variability there, but I will give some basics on how the insulin's used. So you typically have rapid acting or short acting insulin, which you use before a meal, and then long acting, which kind of works as the name implies, long. So again, how it works is we have our blood sugar and we have a meal and it goes up, we release insulin and slowly goes down and we go back to normal, and then it goes up and there's little peaks, right? And in the background, our liver is making insulin or sugar, which causes a little bit of a background. I hope that graph was clear enough for you guys. But my point is that we need to use the rapid acting insulin to cover the carbs or the sugar when we have a meal, gets rid of the peak, gets it kind of back down to normal. And then we also need typically the long acting insulin to balance out the liver's production of sugars, which can also increase it, and to kind of keep the coverage between meals where we need it to be. So typically you're going to see both. I also want to include here in terms of treatments for type 1 diabetes, every type 1 diabetic should have a continuous glucose meter without exception. Dexcom is typically the one we're going to see most, especially when we're using insulin. That makes it safer, more effective, and allows you to better match what you need with where you're at. What I mean by that is when you look at a meal, you have to guess how many carbs are in it and how you're going to respond to it. That's how you match the pre-meal insulin or the bolus. And if you don't know where you're at or how you typically respond to those foods, you kind of have to guess on how much insulin to use. But when you have that continuous glucose meter, that Dexcom, it really gives you a lot of data to understand how you're going to respond. At the same time, insulin can be dangerous when not dosed properly. Specifically, if you use too much of it, you run low. And typically what will happen is patients wake up in the middle of the night, their blood sugar is 40, 45, 50. They have blurry vision, they're confused, they don't know what's going on. They have to rapidly figure out what to do. Versus when you wear a Dexcom, you can set an alert for 50, 60, 70, 80, whatever you want to set it to, and your phone starts beeping. So it basically wakes you up earlier before you have all the symptoms of low blood sugar, allows you to respond. It's much safer. So not only does it allow insulin to be used more effective, but also makes insulin safer. So there's a lot of benefits on CGMs. Most type 1 diabetics are on a CGM, but if you're not, please, please, please call your doctor today and get one. I also want to mention that for type 1s, there often is a new option called an insulin pump. It's not that new, but there's a newer product, which I really educate patients on, that I think is really awesome and great. It's called the Omnipod. So instead of wearing a little pump, which is, not unsimilar to this, as a little tube, and it goes into your body right around here, and you have to wear this with you, the Omnipods are much smaller. So it's basically a wearable pump that's not much different than this in size. You can just wear it on the back of your arm, or you can wear it down here. And what's really cool about it is it holds all the insulin for you, and it does all the insulin injections for you. So if you're tired of giving yourself the injections, which obviously we all would be, it's understandable, when you switch to an insulin pump or the Omnipod, it removes all the injections, which is just life-changing. You have all your insulin with you. So if you go out for a meal, you go out to dinner, you can go on a hike, whatever it is, you don't have to worry about not having your insulin with you when you need it. But I think the most important thing to mention here is a safety and efficacy benefit, because how the Omnipod works is it connects to the CGM and they talk. So every 5 minutes when the CGM measures your blood sugar, it tells the Omnipod makes a decision, which is really cool every 5 minutes. And at the same time, the Omnipod really learns and studies how you respond. So it'll take your last 5, 10, or 15 responses and how you responded and guide the dose based off of that. So my point is that the Omnipod will actually dose the insulin better than a human can, both in terms of safety and efficacy. And it will definitely lower your A1C and definitely change the way you treat your diabetes. So I think that's a really big thing. I also want to point out that most people in their bodies, for non-diabetics, they don't just release all the insulin immediately, and then they don't release a long-acting one. It's little pulses or boluses throughout the whole day. So in my mind, the Omnipod much more closely matches the way your body actually works. And typically in medicine, if we can do something that more closely mirrors the way the body works, that's going to be ideal. There's going to be better outcomes. So there's a lot of benefits. So if you're a type 1 diabetic out there and you haven't heard of the Omnipod, I 100% recommend checking it out. I think it's an absolute game changer. I think it's the future. I'm really excited about it, and it's something I educate all the patients on who are eligible for that. Also, again, just want to quickly disclose here the GLP-1s and SGLT2s as of today are not FDA approved for type 1 diabetics, so I'm not going to talk about those. So it's mainly, again, insulins. So we have rapid-acting insulin, intermediate-acting insulin, long-acting insulin, and very long-acting insulin. And typically what we're going to see, and there's also regular that wasn't mentioned, so I apologize. Typically we're going to see either rapid or regular used to cover the meal. So right before the meal, you give that injection. And typically we're going to see long-acting used once or twice a day in the background. There are insulins called intermediate-acting insulins. Typically NPH is how you're going to see it. I don't recommend those. They don't work as well. It's harder to control the dose, and they just don't work as well because they kind of are in the middle. They're not rapid. They're not long. They're just kind of like in the middle, which isn't how the body works. At the same time, they also often come in a premix one. So you're going to get intermediate and a regular acting insulin, and you're going to use just that one dose. What's bad about that is you can't adjust either of them. So typically with rapid or regular insulin, which is what you use before a meal, you're going to adjust the dose based off the meal. Same with your long acting. You can't do that with the mixed ones. So it's really limiting, but it is typically cheaper, which is why you see patients on it. So whenever I see that, I begin to understand there might be a financial concern. I start to think, how can I get them onto a regular or rapid acting one because they're going to work better. The rapid acting ones typically always end in log. So it's going to be Humalog, Novolog. There's also Abnalog and Fiasp. Those are going to be the rapid acting ones. Those are typically we want to see patients on because they more or most closely mimic what the body does. And then for the long-acting ones, the ones we most commonly see are going to be Basaglar, Lantus. Those are the two main ones. Those are the long-acting ones. They kind of work in the background. And what we've started seeing in the last 5 or 8 years or so is what are called very long-acting ones. So it's typically Tresiba or Toujeo. And what they do is instead of being 100 units per ml concentration, they can be more concentrated. The molecules are more closely packed, which takes longer to release. So typically they have a longer benefit. The long-acting ones like Lantus, they typically work over 16, 18 hours, and a patient may have a gap where towards the end it doesn't offer enough coverage. those patients can switch to the ultra long-acting ones like Tresiba or Toujeo and typically get a 24 or even a 36-hour benefit. So it's kind of the reasons why you would be on that one. The Tresiba and Toujeo currently are both only brand, which typically makes them much more expensive. So between Lantus and the Toujeo, you definitely have a cost concern, and you're definitely going to see that being a differentiating factor between patients and their decisions of which one to use. So typically it's going to be one of those four or a combination. And then again, going back to the Omnipod, you can only use rapid-acting insulin. So it's things like Humalog and Novolog. So it does kind of simplify. You don't have to buy the long-acting insulin anymore, which could save you a little bit of money. So when we're talking about the type 1 patients, we're really talking about how do you want to create a protocol, because we have to find some way to cover all the carbs they're eating and all the sugars their liver's making. So typically, like I said, you're going to use a rapid-acting insulin right before the meal, and you're going to use carb counting and a carb to insulin ratio to get an idea of how many insulin units to inject. So you have to learn to count carbs. So I'm going to look at my meal, and maybe there's 2 slices of bread, so that's 30 grams of carbs, and maybe there's some vegetables or something, whatever, maybe it's 35 or 40 grams of carbs. I know what my ratio is. My doctor told me this, and I decide how much to inject. And then basically I eat the food, my blood sugar goes up, the insulin goes in, does its job, and the goal is for it to very evenly match. If I don't use enough insulin, my blood sugar remains elevated. If I use too much insulin, my blood sugar gets low, I crash. I have a risk of hypoglycemia. Again, this is an example of where the Omnipod is really cool. The Omnipod will basically gauge and dose how much insulin you need, which reduces the risk of overshooting it. And then we also have our postprandial, and which is after the meal, and then our liver's production, because like I said, the liver will produce some sugars we have to account for. That's where long-acting insulins can be used. Again, this will help you keep you within your range and keep you controlled between meals. I also want to mention again that when you're injecting insulin, you typically almost always want to measure your blood sugar before you inject it. That's because if you use too much insulin for how much your blood sugar is, you run the risk of running low, which can become a medical emergency, which is why please, 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 if you're injecting insulin, measure your blood sugar every single time before you inject your insulin, which is why the CGMs are such a game changer, because understandably, nobody wants to prick their finger 4 or 5 times a day, which they would have to otherwise. With the CGM, you can just check it digitally and know how much insulin you need or you don't need. So again, that's why the CGMs are such a game changer. I do want to include anecdotally in my own experience lately, I've been wearing a CGM. I got my Dexcom on right here. And what I've been noticing is it's definitely not 100% accurate. The manufacturer does state that it can be plus or minus 9% roughly. That's what they found in their studies. I definitely see that in my own experience. And I see it as being high and low. And sometimes it can be more than that. So I definitely recommend every couple of days, just prick your finger one time to calibrate it, especially if your blood sugar is unusually high or unusually low. It's a good time to check. The CGM will learn how to better algorithmize, whatever word you want to use there, how your blood sugar is. Because again, the CGMs aren't measuring the sugar in the blood, they're measuring the interstitial fluid. And they have to use an algorithm to convert it to get an idea of what blood sugar would be. And then there's some variation between people. So my understanding is when you calibrate it, it helps the algorithm be more accurate when it estimates. So that's important. And again, this is where the Omnipod comes in, is that the Omnipod basically replaces a lot of carb counting to some extent. It replaces the injections, it replaces the finger sticks. It takes that whole old school way of doing it and puts it into new technology, and the computer doses it for you, which I think is awesome. It's going to do a better job than you do. It's going to be safer than what you can do. You don't have to prick your finger. You don't have to give yourself the injections. You don't have to skip injections. It takes care of all for you. You just have to change the pod every 2 to 3 days, which I think is life-changing. And you get a lot of people out there, they skip injections, they skip testing. So if you're that type of a patient, the Omnipod is probably a good solution for you if you're type 1, because it fixes those issues. And then again, I just want to talk about insulin as a drug. The big issues are going to be weight gain and low blood sugar, like we talked about. And so when you have these options in here, it really helps minimize and prevent that, especially with an Omnipod standpoint. And then everything that I said about statins typically holds true with type 1 diabetics. Most of them have an increased risk for cardiovascular disease. They have an increased risk for atherosclerosis and cardiovascular events. So they're going to be on statins. All the information is the same. They can be on PCSK9s as well if they can't tolerate the statin. And then the last one I want to go over real quick, although it's not technically diabetes, it's pre-diabetes. And it's not typically treated with drugs. I just want to include that for completeness here. So again, the big thing is going to be lifestyle modification. So weight management, diet management, exercise, and just being mindful of it. However, for some patients that have other risk factors, or when they come in, their A1C is maybe like 6 or 6.2, a lot of doctors will put you on metformin. So there's a medication that you can be using for prediabetes. They'll have you follow up in every 6 to 12 months and see where you're at. And the idea here is for you to make those other diet, exercise, lifestyle changes in that phase and basically get your A1C back under 5.7. And then the metformin will allow you to do that more easily. And then once the lifestyle changes take place, maybe discontinue the metformin once you don't need it. So it's kind of a bridge. It's a way to prevent things from getting worse. And like I said, because metformin is so safe, everyone's very comfortable using it. Also want to mention there is the Dexcom Stelo, which is the over-the-counter CGM, which just came out last week. I think this is going to be a complete game changer for pre-diabetics because this is going to allow you to see what foods are bad for you, how your diet's affecting your blood sugar, how your exercise affects your blood sugar, and it gives you a whole new level of insight into what's going on that you wouldn't have had before. And that insight is going to be probably the single best way to prevent yourself from progressing from prediabetes to diabetes. So definitely encourage anyone who's pre-diabetic or worried about being pre-diabetic, like myself, I'm worried about it. Definitely recommend getting a Dexcom Stelo and trying it out, even if you just wear it for 1 month. Right now, they're only available through the manufacturer, so just go to dexcomstelo.com. They're about $90 a month for the 2 sensors. Even if you just wear it once, absolute game changer, highly, highly recommended. And then also some pre-diabetics may require statin. So that's about it for today. If anyone has any questions who's following along, feel free to put them in the channel right here and I can address them. I know that's a lot of information. Like I said, the goal is to really just do a quick overview to give people some basic ideas, to throw out the drug classes, some of those common medication names to help your understanding. And again, to really emphasize that there are some really new medications that work really well. I definitely encourage patients who are eligible and who can afford those to try those. The benefit is quite a bit. I also recommend trying to avoid those older medications if you can, like I mentioned, because I personally and professionally don't think they work as well. They have more side effects. For patients that are type 1, definitely please be careful with your insulin because if you dose it wrong, it can be a serious problem. Definitely make sure you're using a CGM to keep yourself safe with the alarms and the alerts. And if you're not already on an Omnipod or haven't heard about the Omnipod, I definitely encourage you to talk to your doctor about that because that's an absolute game changer. And for the people out there who are pre-diabetic, metformin could be a good solution or fit for you until you get other lifestyle modifications dialed in. So I know there's a lot of information. I appreciate you guys for watching. Again, my name is Chris. I'm the Helpful Pharmacist. I'm a biochemist and a pharmacist. And again, I think knowledge is power, which is why we're here today. I want to educate you on what's going on. If you like this information, please follow our channel or check out our other videos and subscribe. We have a whole series of diabetes videos we've made. This is the 4th video with more to come. They're pretty comprehensive. If you have any questions, you can put those in the comments below or email me at work, which is going to be welcome@yourpersonalpharmacy.net. For anyone in the San Diego County area, I operate a pharmacy in Fallbrook, California. More than happy to talk to you about taking care of your pharmacy needs. And we also have an online supplement store on our website at www.yourpersonalpharmacy.net. So if you're someone who struggles figuring out what supplements are going to be best or safe or all of the above, you can definitely check that out or send me an email for a free consultation. I explain all the information to you about what I think is best for you. Thank you for following along. I hope you guys learned something. Have a great day and take care.